Good evening or good morning or whatever time it is. I'm talking to you from Sweden, which is on the other side of the earth. My name is Claes Möller. I'm an ear, nose and throat specialist, but I have been working with deafblindness and Usher syndrome for almost 30 years. I had the luck to be part of finding the genes, and I have met over 500 families in different countries with Usher syndrome, and I'm so very pleased to be able to speak to you in Australia about the interdisciplinary work that it needs to be done with children with Usher syndrome. Australia is a big country. I've been there many times, and I also have had my children as exchange students in Australia, and they are twins, and they were so happy that both came to Australia because they could see each other for 1 year. The only problem was that one ended up in Sydney and the other in Perth. So it is a big country, and Sweden is a very small country geographically compared to you. So the urgency of the interdisciplinary healthcare and support for people with Usher syndrome. I went to the doctor and he told me that I would go deaf and blind. He does not know why, not when, but it might be in the near future. Then the doctor abruptly left the room. No, not my hearing, not my vision. It's not fair. How could God do this to me? Why wasn't I told up until I was grown up? Somebody there helped me. This is a quite common comment that I often hear, especially when I diagnose people with Usher syndrome that are teenagers or a little bit young adults. And this is what we have to avoid, because late diagnosis means severe crisis. Why is it important to know the cause? Well, of course, to get the correct diagnosis, because many different deafblind syndromes can be similar but can have very different prognosis, and also to learn from other experiences. We also need to have correct rehabilitation, and as you will see at the end of my speech, treatments are specific to the cause, and treatments are on the way right now. And one can avoid or justify other expensive tests. Maybe the most important thing is that family often want and need a reason for the problem. And the more you know as a family, the better the rehabilitation or habilitation will be. But this demands a very thorough interdisciplinary work between professionals and family. We have many senses. The most important are the far senses for humans, since we are social animals that communicate, which means eye and ear. The other senses are important, but not as important. Smell is important, and tactile information is important. Taste, not so very important. The eye and the ear is very similar, and especially deafblind research and genetic research have shown and are showing that the eye and the ear works in very, very similar ways. And when you go down to the cells, you can see many similarities. And that is probably why so many syndromes that affects the ear also affects the eye. We have the hair cell in the hearing organ with its small stereocilia, and we have the rods and cones in the eye, and they are, as we have seen, very similar. And they also develop at the same time. So, do I have a patient with a problem? Can you see anything in this child that would make you suspect that this child might, in this case, have Usher syndrome? No. This is one of my grandchild and he is perfectly healthy. But does this child have a syndrome? I'm quiet a little bit so you can look at the picture and decide if you can find anything. Yes, this child has Usher type 1. He's profoundly deaf. He already has some small vision problems, they're barely notable, and he has bad balance. But you can't see it. And that is the important message. When a child is small, you have to have good skills and good medical diagnostic tools in order to diagnose Usher syndrome. Now, what about this girl? Same girl on both pictures. Well, the picture to your left, you can see that the girl is a little bit stressed. She doesn't like the sun. She has a little bit of stressed face. But on the other picture, she has put on sunglasses and a cap, and her face is much happier. So at this age, you will probably start to notice, but wouldn't it be good to have this knowledge very early so you can make the best of a child's life and not a lot of misunderstandings? So, early identification of deafblindness. If we look at hearing, in Australia, as in other Western countries, we have universal neonatal hearing screening. But all children with Usher syndrome have a wrong diagnosis at the beginning because they are diagnosed as a non-syndromal hearing loss, because the hearing loss is detected at the first or second or third week. So if we look at genetic screening for hearing loss, which is a tool which we should use today, we can assume, let's say 200,000 births. I don't know, could be Australia, maybe 250,000. If we have 200,000 births each year, you will know that approximately 400 of these children will have a hearing impairment that will be so pronounced that it needs habilitation. Out of those 400, maybe 160 will have a congenital prelingual profound deafness. And thus 240 moderate to severe hearing loss. 60 cases will have what we call connexin 26, a non-syndromal hearing loss deafness. But 15 statistically will have Usher type 1, 25 Usher type 2, and in Australia, maybe 5 with Usher type 3. And this is the children that we need to discover early. But this is a very, very important message. A positive genetic finding, if you do a genetic testing, a genetic finding for Usher syndrome is not Usher until the eye problems are diagnosed. Because there are some mutations today that only give hearing loss deafness. And this is so important because many, many physicians out there think that if you get a positive mutation for Usher syndrome, it will be Usher syndrome. So when a child has a hearing loss, these are some of the professionals that we need to have to cooperate. An otolaryngologist, psychologist, radiologist, maybe cochlear implant teams, audiologist, teacher, geneticist, and parents, which is the most important. The more the parents know, the better the rehabilitation will take place. If we go to vision, we have to say that vision care for deaf children and young people It's not just the eye doctor in Usher syndrome, as I will show you. And we need very good guidelines for professionals. We have to realize that a severe vision loss in a child is much more uncommon than a hearing loss, which means that many of our eye doctors, ophthalmologists, very rarely see a child with a combined hearing and vision loss. Maybe one or two in a lifetime with Usher syndrome. So children with hearing loss, if we look at some literature findings, 20% of children that are 7 years of age with normal hearing have some sort of visual impairment. Might be very mild. But if we look at children with hearing loss, 50% of them have a visual impairment. Of course, it's not severe in all cases, but it can be much more severe in a case where a child has a hearing loss as well. So a mild myopia when you're nearsighted might be very, very severe if you can't lip read, etc. So therefore, we need a small vision loss can be severe, and we need mandatory visual examination. And we in Sweden are to some degree in conflicts with ophthalmologists. How often should we examine children for vision loss? And as you know, in Usher syndrome, it's not just to look at the sign and have reading pictures or letters, because that will not be effective primarily in Usher syndrome. This is a picture of retinitis pigmentosa. To your left, you have a normal fundus, which we call the retina in the back, and to your left, right, you will have a typical pattern when it's an advanced retinitis pigmentosa. This is not the picture you will see in children, because children don't have these black spots, which are dead rods. This is to try to imagine how you can see. You all, most of you know that the first sign in a child is that the darkness vision will be slightly impaired. They might also be very sensitive to sun, etc. And later, there will be a vision loss, a visual field restriction, sort of a tunnel vision. This is how a teenage could see this picture. Look at the picture for 5 to 10 seconds, and then you will see a new picture. Try to remember what you see in the picture. This is a picture 20 to 40 years. What differences do you see? Is there anything that you miss from the first picture? Look at the white haystack in the right corner. So if you are talking, when you look out, you have to realize that a lot of information is missing. And this, of course, gets even more true if you are talking with different people that are either signing or talking and are standing outside your visual field. Now, the good thing with Usher syndrome is that very, very few people get totally blind. Most people, adults, will have a residual vision. And this is so important to tell, especially our teenagers who have this existential fear of going blind quite soon. There will be problems in darkness, there will be problems in bright sunlight, but most of them will have up to the 50s, 60s, or 70s, a very quite good central vision. In order to diagnose retinitis pigmentosa early, you need electroretinography, ERG, and in small children under general anesthesia, which means they have to be put to sleep. This is so important. You can't rule out Usher syndrome or confirm it without an ERG. This is a very early sign for retinitis pigmentosa, much earlier than what you can see when you look into the eye. And a lot of eye doctors are quite reluctant, and this is a special test that is only done in large hospitals. But I think that every child, when you suspect or you get a genetic diagnosis of Usher syndrome, should have an ERG as soon as possible. So, identification of children with possible Usher 1 to 4 years. Vision, general anesthesia, fundus photography, something called OCT. You have to do ERG, and today you can do with what we call full field, the whole retina, or you can also make it multifocal, where you look at different parts of the retina. Of course, visual acuity, visual field, darkness adaptation, contrast, light sensitivity. And on the right side, you can see where I have listed which are good when you're young and which are not so good. Now, this is just the medical part of it. We need so much more. When a child or adult have vision loss due to Usher, we need ophthalmologists, we need obstetricians, teachers who has to know a lot about deafblindness, orthoptists, low vision clinics. Maybe they get cataract later and you need cataract surgeons. So you need parents, family, and professionals. Unfortunately, in Sweden, many children are diagnosed too late, which means that teachers and others have misunderstood them for a long time. If we look at balance, we know that the balance system is comprised of eye, signal from the muscles, the skeleton, the tendons, and the vestibular system in the inner ear connected to the cochlea. These two work together in order that we can have a good balance. If you have Usher type 1, we all know that from the very beginning, there are no vestibular signals. The vestibular organ is, so to speak, deaf. You still have good muscles, etc. But when the eyes get worse, your balance will get worse. Now, if you are a young child, a newborn with Usher type 1, your motor milestones will be later than other children. And this is Usher type 2 balance. So, if you look at walking age, we know that the vast majority of children with Usher type 1 have a walking age later than 18 months. And the trick is, of course, to go to a good ENT that can do a vestibular testing by rotating the child and looking at the eyes. A quite simple test that many miss. If you have Usher type 2, the walking age is normal. You could also ask the parents about delayed motor milestones. You can see that the Usher type 1 child is quite clumsy, especially very early in darkness or uneven surface, difficulties learning to bicycle, gymnastic sports, no fun because they get a little bit later than others. One advantage is that you can't get motion sickness if you have Usher type 1 because you need vestibular organs for that. But these children need extra gymnastics, extra sports, and if they are small, they need a physiotherapist that can encourage and train balance, which means training the eyes, training the somatosensory system, the muscles, etc. This is a slide showing the mean diagnosis age depending on when you were born. If you're born in the 1920s, 1930s, Usher type 1 in Sweden was diagnosed at 28 years, if it was ever diagnosed, and even later in Usher type 2. So if you look what has happened the last years is that Usher type 1 is diagnosed in Sweden at around 1 year. And I mean diagnosed, not just genetic, but clinically also with ERG. And that is, of course, because Usher type 1 are deaf and get cochlear implants, which means we have been so much more interested and are doing much more investigations. Unfortunately, Usher type 2 is still not diagnosed as early as this, even if it has gone down the last decades. If we look at rehabilitation in Usher type 2 as an example, we know that the hearing loss is discovered early, vision problems are more discreet. I don't know how others see. How can I explain that I can't see very well in darkness? All difficulties in school will be caused by the hearing loss, at least you think so. Contrast, light sensitivity, darkness, can't really see when they turn out the light in the classroom. Late diagnosis in my patients are always denial. When you're a teenager, you want to be like the rest. So teenagers is a very, very difficult age to get the diagnosis. Can't get a driver license, which is for some people the most important at that age. So this is not what I have planned. Crisis, depression, anxiety, maybe acceptance. And this craves a lot of teamwork with professionals, patient, and family. And this is so essential. This is a very busy slide, and you might have a look at it after the speech. It just shows that we have done a lot of research on psychosocial health in Usher syndrome. And what we can see is that all people with Usher syndrome have some severe psychosocial and physical and psychological problems. Fatigue, suicide thoughts, which is very stressful, and also suicide attempts. And if we look into a normal population, all these bars you see here are much higher than what you can see in a normal population. And this is probably due to not so good rehabilitation. Because if you have good rehabilitation, many of these problems can be avoided. This is how it looks like in Sweden. This is Swedish, you can't read it. But every small part here is some agents which you have to rely on or which you have to discuss with when you have a deafblindness. And you can think about how many you see each week of different agents. And now look at this. This is a tremendous work for a patient with Usher syndrome or a family with a child. So what do people with Usher syndrome need? They need a medical and functional diagnosis. They need personal knowledge concerning deafblindness, different support depending on age, knowledge among caregivers, good follow-up on hearing, vision, balance, physical and psychological health. But they need communication, they need activity and participation. And if you look at those three, communication, activity, and participation, if you withdraw this from people, they get very depressed. The best thing to torture a person is to isolate him or she, and also maybe in darkness. So this is one of the main things for us who are professionals, to work together in order to give the resources to persons with Usher syndrome. And also, people need research, which hopefully will give us treatment very soon and maybe cure. And the multidisciplinary team, researchers, work with evidence-based medicine, which means go out and look on the internet. How do other people do? Don't sit there in front of your patient and say, I've never seen anyone with Usher syndrome, never heard about this. The professionals have no excuse today not to know because there is so much information out there. You need audiology, ophthalmology, sometimes psychiatrists, genetics, psychologists, sociology, education. And in my dream world, we would have all these, and we will have a coordinator, a person that can take contact with different specialists instead of that the family has to drive and shepherd all the professionals in front of them. And we need, of course, the patient and the family. And we need a cooperation together. The future, well, actually it is here. We have the possibility of doing a clinical, good diagnosis, early diagnosis, combined with the genetical diagnosis. This gives us the prognosis. It will give us early habilitation, but it will also very soon give us possibilities of treatment. There are trials now, treatment trials for different genetic forms of Usher syndrome. They are done in adults, but of course, if it's successful in adults, it will be the kids that are the main people that will receive this treatment. And it also might be that we will have a cure for Usher syndrome. And especially for your children who are very young now, look back 20 years what has happened. I've been in 30 years in Usher syndrome. When we started together with an institution in America, we had no idea that there were 1 or 5 genes and what they were causing. And when we discovered the first gene, it's only 25 years ago. And we are a long way ahead. And the research is exponential, which means it goes faster each year. So 25 years from now, I'm convinced that your children will then be 25, 30 years, there might be a cure. So Usher, new possibilities, information technology, inner ear metabolism, that we know much more what happens in the eye and the ear, treatment, genetics, cochlear implants, which are already here, cooperation, communication, and knowledge. See that your children get knowledge about Usher syndrome. So, vision, hearing, and tactile information work together and help each other. This is a special technique where you can see some of the largest nerve cords in the brain that work between the front and the back of the brain, between the two halves of the brain. And this is just a very, very large nerve fibers. Behind this are millions and millions of nerve cells working together. So the brain has a large capacity to encompass even severe dysfunctions and can change strategies. Cochlear implants at final is a tremendous good opportunity to learn speech and to hear for children with Usher type 1 and some adults with Usher type 2 and especially adults with Usher type 3. But my main point today, which I will end with, is don't just trust the hearing system. Use both hearing, tactile, and vision. And if I go blind, and if the cochlear implant doesn't work, you might want to have another language. So my philosophy is that children with Usher type 1 should learn, of course, if they have cochlear implants, to hear and to speak. But it would be a good idea to have the second language as a visual sign language. Even if you don't have so many to communicate with, learn visual sign language, because one language which you have learned as children will be very easy to pick up. And it's extremely difficult to learn tactile language tactile sign language if you are so visually impaired that you can't see signs. So this is one thing, and since I'm working with cochlear implants, I know that most cochlear implants teams wouldn't understand what I'm talking about and would probably disagree. I would like to end this speech and thank you all for listening by Helen Keller, who she said, although the world is full of suffering, it is also full of the overcoming of it. I hope you are having a very, very good conference, and I hope to see some of you at the Deaf Blind International Conference, which will be on the Gold Coast next year. Thank you and goodbye from Sweden.